I'm on 101.1 FM. It is also being streamed live on UI website with the address www.live.ui.edu.ng, as well as official YouTube channel at UI Premier TV. Distinguished ladies and gentlemen, inaugural lectures in the University of Ibadan are very significant to our reputation, particularly in the pursuance of excellence in our day-to-day academic activity. We will appreciate your cooperation by observing a solemn atmosphere throughout this lecture. That includes moving forward to occupy seats in front of you so that those coming late won't be jostling for seats in between, they can sit from behind. We will also appreciate one more time that you put your phones on silent mode to avoid distractions during the delivery of today's lecture. The Vice Chancellor, Professor Kayode Oyebode Adeboale, MNI, FAS, duly appreciates your presence at this lecture. Thank you, and you are most welcome. The academic procession will be filing in any moment from now, and you will be signaled to rise up on your feet as it files in once that is about to commence. May I request those at the lobby to please come into the auditorium. Can I have one of the ushers up here, please? please come in and clear the main entrance. Those are the lobby should please come into the auditorium. Can you please rise as the academic procession files in? Please clear the middle aisle. Once the academic procession files in and the main door is shut, nobody is allowed to move along the middle aisle.
Deputy Vice Chancellor Administration, Deputy Vice Chancellor Academic, Deputy Vice Chancellor Research, Innovation and Strategic Partnerships, the Registrar, the Bursar, University Librarian, Provost of the College of Medicine, Provost of the Postgraduate College, the Dean of the Faculty of Basic Clinical Sciences, Deans of other faculties and of students, Directors of institutes and centers, Heads of departments, distinguished guests, ladies and gentlemen. The 597th University of Ibadan Inaugural Lecture will be delivered this evening by Professor Taiwo Kotila of the Department of Haematology on behalf of the Faculty of Basic Clinical Sciences. Professor Taiwo Kotila was born in Lagos into the family of late Major Michael Ayodele Kotila retired and late Mrs. Alice Abike Kotila on the 29th of September 1960. Both parents hailed from Ifaki, Ekiti in Idosi local government area of Ekiti State. She received her early education at Ibadan City Council Practicing School, Okebola, Ibadan. She then proceeded to the Methodist Girls High School, Ifaki, Ekiti, between 1972 and 1977 for her secondary education. Thereafter, she gained admissions to the University of Ibadan and graduated MBBS in 1987. She started her residency training in hematology at the University College Hospital, UCH Ibadan, in 1990 and completed her training in 1997, becoming a fellow of the National Postgraduate Medical College of Nigeria. She worked briefly at the Federal Medical College, Owo, as a pioneer head of pathology division and a consultant hematologist. She joined the staff of the Department of Haematology, University of Ibadan, in 1998 as lecturer grade 1, was promoted to the rank of senior lecturer in 2001, reader in 2016, and professor in 2019. Professor Kotila is an honorary consultant to the University College Hospital, Ibadan. She obtained a Master's of Science degree in clinical trials from the London School of Hygiene and Tropical Medicine. She was a visiting research fellow at the Department of Haematology, Hebrew University, Jerusalem, Israel, in 2009 and 2010, during which she acquired expertise in the use of molecular methods in the diagnosis of the hemoglobinopathies. The visit was sponsored by a scholarship from the Royal Society for Tropical Medicine and Hygiene. She returned to Hadassah Hospital in Jerusalem, Israel in 2016 when she spent her sabbatical leave in the department for bone marrow transplantation and immunotherapy. Professor Kotila has served the University of Ibadan in various capacities. She was twice the acting head of Department of Haematology in 2013 and 2021 and was subbed-in undergraduate of the Faculty of Basic Medical Sciences between 1999 and 2002. She is presently the Dean, Faculty of Basic Clinical Sciences, College of Medicine of this university. She was and is still a member of the department, faculty, College of the university. She has supervised and co-supervised and is still involved in the supervision of fellows of the National Postgraduate Medical College, the West African College of Physicians, PhD and master students within and outside her faculty and the country. She has served as external examiner to Olabisi Onabanjo University Agoiwoyi, Afe Babalola University Ado-Ekiti, and the University of Ilorin. He was a visiting scholar to the School of Medicine and Allied Health Sciences at the University of Gambia in 2022. Professor Kotila received the Dr. Charles Majekodunmi Prize for the best Part 2 FMC Part candidate in hematology in 1997. In addition, she also received the Young Investigators Award of the Nigerian Society of Hematology and Blood Transfusion for the year 2000. She is a member of many professional associations, notably which include the College of Nigerian Pathologists, where she chaired the Oyo State branch between 2019 and 2021. She was the treasurer of the Nigerian Society of Haematology and from 1999 to 2002. She was a member of the Diversity, Equity, and Inclusion Committee of the International Society of and the Hemostasis from 2019 to 2021. He was also a member of the Guardians and Guidelines of the same committee between 2020 and 2022. She is currently the director of the UCH Hemophilia Treatment Center, an affiliate of the World Federation of Hemophilia. Professor Taiwo Kotila is an astute clinician and avid researcher of international repute. She has over 70 publications in peer-reviewed journals. She is a recipient of many grants, including the Senate Research Grant, one of the first recipients of the University of Ibadan Research Foundation, a recipient of the Royal Society of Tropical Medicine, Centenary Award, European Developing Countries Clinical Trial Partnership Travel Fellowship, the World Federation of Hemophilia Research Support Program. Her research interest is the hemoglobinopathies, especially in the characterization of beta thalassemia, which was thought to be of little clinical significance among Nigerians until now. Although she has carried out research in different aspects of hematology, her works, especially beta thalassemia, shall be the focus of today's inaugural lecture. Distinguished ladies and gentlemen, and I invite Professor Taiwo Rachel Kotila to deliver her lecture, which is titled Unmasking the Masquerade, the story of two sisters' disorders. Professor Kotila.
The Vice Chancellor, Deputy Vice Chancellor Administration, Deputy Vice Chancellor Academic, Deputy Vice Chancellor Research, Innovation and Strategic Partnerships, Registrar, Bursar, Librarian, Provost of the College of Medicine, Provost of the Postgraduate, Dean of the Faculty of Basic Clinical Sciences, Deans of other faculties and of students, Directors of institutes, Heads of departments, distinguished ladies and gentlemen. I consider it a great honor to deliver this inaugural lecture on behalf of the Faculty of Basic Clinical Sciences and the Department of Haematology. This is the second lecture from the Faculty of Basic Clinical Sciences and the fifth from the Department of Haematology. Two of the previous lectures from the departments were on hemostasis, and the last one was an overview of hematology. This is the second lecture on hemoglobinopathies. The first lecture delivered by Professor Yetunde Akanova was titled The Streams of Life. The first lecture from the departments was delivered by Professor Etim Essien in 1989 and was titled May Our Blood Flow Freely Within Us. This was followed by the inaugural lecture by Professor Akanova in 2005. The third lecture, titled Bleed Not My Son, was delivered by Professor Wura Olashokunbi in 2011, while the last lecture, titled Blood Cells Eccentricity, Looking Out and Looking After the Afflicted, was delivered by Professor J. A. Olaniyi in October 2024. Today's lecture, which is titled Unmasking the Masquerade, A Tale of Two Sister Disorders, will describe the similarities between sickle cell anemia and beta thalassemia. These similarities have made the diagnosis of beta thalassemia difficult till date. This 597th inaugural lecture is the second in the fledgling Faculty of Basic Clinical Sciences, barely 1 year after its creation. Meanwhile, only 3 lectures were given by the department in over 5 decades of the creation of the department while in the Faculty of Basic Medical Sciences. This is a sign that the creation of the Faculty of Basic Clinical Sciences is a wise decision and will yield greater dividends for the university when fully and properly positioned. Mr. Vice Chancellor, sir, kindly indulge me to tell this audience the story of my journey into the field of medicine and of hematology. As a young girl, I got carried away by the euphoria of crossing into Form 3, where you can now show off the study of physics, chemistry, and biology, rather than the integrated science of the preceding 2 years. I became playful. It was not surprising that along with 2 other friends, I got a very low mark, 11% in chemistry. My chemistry teacher swore not to allow us derail under his watch. He ensured that we moved from being backbenchers to sitting in the front row in his chemistry class. Thereafter, he would direct all questions to us during his class. It was only after he had scolded us for failing to give a correct answer that he would ask other members of the class. Needless to say, I got 80% in the next class test and was the only one who ended up in the science class out of the 3 of us. Shortly after, Mr. Osointui left the school for further studies. Now my journey to hematology. At my final MBBS exam in internal medicine, my long case was a patient with chronic lymphocytic leukemia, a blood cancer. The external examiner discussed my good performance with the internal examiner, Dr. Lawal, a cardiologist, who then responded that maybe she would like to be a hematologist. I only smiled within me since I had my eyes set on being an ophthalmologist. The declaration by Dr. Lawal was prophetic. After my NYC, I took up employment in a private hospital whilst trying to prepare for the primary examination in ophthalmology. In the process, I got tired of private practice. I then learned of a residency position in hematology, which I applied for with the mind of crossing over to ophthalmology as soon as I passed my primaries. Fortuitously, the then head of hematology, Dr. JJ, the him of oxygen in the body. The globin portion is made up of chains of amino acid, which distinguishes one hemoglobin variant from another, while the heme portion is made up of a porphyrin ring and a central ion atom. The ion is designed to be in the ferric hemoglobin. Disorders arising from the hemoglobin are mostly inherited and could be classified into 2 broad groups. Porphyrias being disordered red cell. This gel formation results in the sickling of the cell. That is a change of the cell from the normal discoid shape to the shape. Red cell easily gets tangled within the blood vessel, clogging the vessels, especially small blood vessels, which directly supply tissues and organs with blood. It is therefore not surprising that the complications of sickle cell disease can be found in all of the red cell. The normal lifespan of the red cell is therefore reduced from the expected 120 days to 17 to 20 days. This recurrent hemolysis is responsible for recurrent anemia and jaundice, which are stigmata of the disease. Certain hemoglobins ameliorate sickling phenomenon, which makes them a target of therapy for sickle cell disease, notably of which is hemoglobin F. A good example of such drugs is hydroxyurea, which increases hemoglobin F levels. Other hemoglobins, like hemoglobin C and D, when co-inherited with hemoglobin S, give different genotypes of sickle cell disease, like hemoglobin S plus C or hemoglobin SD, because they encourage polymerization of the S hemoglobin. Among the D hemoglobins, the most notorious is the D Punjab, which results in sickle cell disease. However, inheritance of the hemoglobin D prevalent in Nigeria, hemoglobin D Ibadan, does not result in sickle cell disease phenotype. Therefore, such individuals remain asymptomatic and are not classified as having sickle cell disease. The epidemiology of sickle cell disease. Nigeria has the highest burden of sickle cell anemia in the world. This is a consequence of the large population with a prevalence of 1 to 3%. Similarly, the country has the highest prevalence of sickle cell traits, which is 25 to 30%. This contrasts with the prevalence of 8 to 9% among African Americans, 7 to 14% in the Caribbean, and less than 1% in South Africa. This underpins the role of malaria endemicity in the prevalence of sickle cell disease across the globe and the role of the transatlantic slave trade. It is worthy of mention that Ghana and Burkina Faso have the highest burden of hemoglobin C gene in the world, with a prevalence of 20%. The thalassemias, these are quantitative defects due to reduced or lack production of alpha, beta, delta, or gamma chains, or various combinations thereof. The disorder is named after the chain that is not produced at all or produced in reduced amounts. The other chains are then overproduced in a compensatory mechanism, which is nature's way of trying to overcome the challenges. It is rather than the underproduced chain that is responsible for the clinical problems of the disorder. Precipitation of the overproduced globin chain results in chronic hemolysis and ineffective erythropoiesis. Alpha thalassemia trait affects about half of the Nigerian population. The severity of alpha thalassemia depends on the number of alpha chains that are affected. Ideally, there are 4 alpha chains in an individual. So 1 to all 4 chains could be affected in an individual. Studies have shown that the alpha thalassemia seen in Nigeria is of the mild type because only 1 chain is mostly affected. The severe forms affecting more than 1 chain are rarely seen among Nigerians and are mostly seen in the Southeast Asians. The beta thalassemia are by far the most common and significant forms of the thalassemias. This is because apart from the chronic hemolysis which could occur in them, iron overload is the major cause of the complications observed in patients with the disorder. The iron overload occurs primarily because of frequent blood transfusion. Iron overload could also occur because of increased iron absorption from the gut in the absence of chronic blood transfusion. There are a lot of similarities between the clinical features and the complications of beta thalassemia and sickle cell disease. This would explain the difficulty in diagnosing the former, as patients with features of beta thalassemia are assumed to have sickle cell disease, even in the absence of evidence for this. Also, the hypochromia and microcytosis of the thalassemia is assumed to be due to iron deficiency, even when iron levels show otherwise. Beta thalassemia can be classified into 3 major types, depending on the clinical severity, which hinges on the frequency of blood transfusion. The classical region about every fortnight from childhood. This is the thalassemia major with a stigmata akin to that of sickle cell anemia, bursting of the skull, long thin extremities, protruding abdomen, etc., etc. The beta thalassemia trait is the mildest form which may go through life undetected. These patients in whom hematocrit is suboptimal may never be transfused in a lifetime, only requiring blood transfusion during pregnancy or other stressful conditions. The thalassemia intermedia is often not transfusion dependent until later in life and is referred to as non-transfusion dependent beta thalassemia. However, complications of iron overload may occur early because of increased iron absorption from the gut. In most cases of beta thalassemia, the red cell indices are low, which reflects the hypochromia and microcytosis associated with the disorder. The red cell indices are therefore good screening tests for beta thalassemia, though alpha thalassemia and iron deficiency anemia may also have low red cell indices. The presence of iron overload with low red cell indices differentiates beta thalassemia from alpha thalassemia and iron deficiency anemia. However, an elevated hemoglobin A2 on hemoglobin fraction analysis is the hallmark of the beta thalassemia trait and is diagnostic. The percentage of hemoglobin S on hemoglobin fraction analysis could also help in differentiating sickle cell traits from sickle cell beta thalassemia traits. In sickle cell traits, the percentage of hemoglobin S is between 25 to 40%, while it is greater or equal to 60% in S beta thalassemia. It should, however, be noted that normal red cell indices or hemoglobin A2 do not rule out beta thalassemia, especially in Nigeria, where the prevalence of alpha thalassemia is high. This is because the imbalance that should have occurred with beta thalassemia is offset by the presence of alpha thalassemia. Hereditary persistence of fetal hemoglobin. This is a group of conditions in which there is persistence of fetal hemoglobin synthesis into adulthood in the absence of significant hematological manifestation. This condition has a lot in common with beta delta thalassemia. It is now considered semantics trying to differentiate between hemoglobin F, hemoglobin persistence of fetal hemoglobin and delta beta thalassemia. Mr. Vice Chancellor, sir, my contribution to knowledge. Clinical severity of sickle cell disease. My earlier studies revolved around the severity of sickle cell disease and the role of hemoglobin F, a focus of my research dissertation for the National Postgraduate Medical College of Nigeria. I did the work as a resident doctor under the supervision of Professor Wura Olashokunbi. We observed that the mean hemoglobin F level among Nigerian sickle cell disease patients is 7.4%, Kotila et al. 2000, similar to the reported value of 8% for the Benin haplotype. This categorizes Nigerian sickle cell disease patients as having a severe disease phenotype. Previously, there was the myth that sickle cell disease patients would not survive past their 21st birthday, though the mean age of our cohort of patients then was 22 years. 14% of them were older than 30 years, Kotila and Shokunbi, 2001, thus giving hope of better survival. We now have patients in their 60s and the occasional patients in their 70s. In the same study, we observed that 25% of patients claimed to rarely have bone pains, and another 27% had never been transfused, Kotila and Shokunbi, 2001. Dactylitis are not or commonly the heralding signs of sickle cell disease in Nigeria. We observed that this pathology could accurately predict the severity of the disease, Shokunbi et al., 2001. It is known that multi-organ failure contributes to the observed morbidity and mortality seen in sickle cell disease. Though the liver is a major organ that is affected, the prevalence of liver disease is difficult to ascertain. Despite observing their liver enlargement in 77% of our patients with good correlation between the degree of jaundice and liver size, 25% had normal liver enzymes, and only 13% had elevation of the 3 liver enzymes. In addition, 22% and 5% of our patients showed derangements of PT and APTT respectively, Kotila et al., 2005. Malaria chemoprophylaxis in sickle cell disease. Malaria is endemic in tropical Africa, and it is believed to explain the constant level of the prevalence of sickle cell traits over generations, a concept known as balanced polymorphism. Furthermore, malaria is also a known modifier of other inherited red cell abnormalities apart from the sickle cell disorder. Therefore, infection by malaria is a non-culprit for the frequent vaso-occlusive crises in sickle cell disease patients, hence the need for regular malaria prophylaxis. However, due to the high cost of proguanil, the drug of choice for malaria prophylaxis, many patients are not adherent in its use. Adejumo et al., 2002. We therefore looked at asymptomatic parasitemia in sickle cell disease and observed that the degree of parasitemia did not differ between those on chemoprophylaxis and those not on prophylaxis. Also, malaria was more frequently treated by sickle cell disease patients than healthy controls. Kotila et al., 2007. We therefore concluded that the observed protection by chemoprophylaxis may be due to the frequent treatment of malaria, irrespective of the outcome of a test for malaria. We suggested that intermittent preventive treatment of malaria, as done in pregnancy, may be beneficial in sickle cell disease. However, careful selection of the choice of drugs for IPT is important, since the drug will be used for a lifetime rather than a short period as done during pregnancy. There are individual variabilities in the metabolism of drugs, which may largely be due to racial differences. Though diseases also affect drug metabolism, we therefore compare the prevalence of the CYP2 C19 genotypes in sickle cell disease patients and apparently healthy controls. We observe that Nigerian sickle cell disease patients are good metabolizers of proguanil, and only about 1% of the patients were poor metabolizers of the drug. Babalola et al., 2010, Adejumo et al., 2016. The thalassemias. The characterization of the thalassemias was first done by Professor Folaison, one of the founding fathers of hematology in Nigeria. He had characterized both alpha and beta thalassemia in his PhD thesis and reported his findings in a seminal publication of the British Journal of Haematology, Eson GJF, 1970. The observed low prevalence of beta thalassemia traits of less than 1% was due to the method available for diagnosis at that time. Mr. Vice Chancellor, sir, my interest in thalassemia was because of the observation that some individuals who have the sickle cell traits and so should be asymptomatic have symptoms akin to what is found in sickle cell disease. Sickle cell traits with symptomatology is now gaining global recognition. Affected individuals now have a global movement with a Facebook account. After this observation, I decided to make it the objective of my project for the West African College of Physicians in Laboratory Medicine. Unfortunately, the dissertation did not meet the expectations of the college, so it was thrown out, though I had the best results in the exam. However, the findings of the studies were published. The study design was a case control of 10 sickle cell trait individuals with symptoms suggestive of hemoglobinopathy and 20 sickle cell trait individuals without such symptoms, apparently healthy control. Hemoglobin A2, hemoglobin F, hemoglobin S were quantified by elution in all participants. There was a marked significant difference in the levels of hemoglobin A2 and hemoglobin F between both groups. Also, 9 of the patients and none of the controls had elevated hemoglobin A2, Kotila, 2007. To explore our findings further, we investigated hemoglobin F levels in 50 apparently healthy Nigerian adults who have hemoglobin A and 20 apparently healthy heterozygotes for comparison. We expected to find hemoglobin F levels below 1% in the participants, being healthy adults. However, our findings showed elevated levels in the majority. Only 19% had hemoglobin F levels below 1%, with 22% having values above 3%. There was no significant difference between the mean hemoglobin F between hemoglobin A and hemoglobin AS individuals. We concluded that this might be due to hereditary persistence of fetal hemoglobin in the community and might not be unrelated to the high frequency of sickle cell disease and beta thalassemia, Kotila and Shokunbi, 2003. In a related study, we looked at hemoglobin F and hemoglobin A2 in healthy individuals. Among these apparently healthy individuals, 26% had elevated hemoglobin A2, suggesting the possibility of undiagnosed beta thalassemia traits, giving a prevalence of beta thalassemia traits of 26% among Nigerians. Kotila et al., 2009. This hypothesis was supported by our findings that beta thalassemia, a quantitative hemoglobinopathy, may be responsible for the elevated hemoglobin F and hemoglobin A2 in apparently healthy individuals, and for sickle cell trait individuals having symptoms suggestive of sickle cell anemia. A major shortcoming of the method used for the laboratory diagnosis of beta thalassemia traits in the above studies is that it was done by elution, manually, and not by automation. This is because at the time of the study, quantitation of hemoglobin fractions by automation was not available in the country. Another pitfall was that red cell indices were not used as screening tests, since this could not also be done by automation. Alpha thalassemia. The desire to confirm the findings of high prevalence of beta thalassemia trait at the molecular level was responsible for my visits twice to Hadassah Hospital in Jerusalem at the initial recommendation of a dear family friend, Professor Femi Adeleye. Like my colleagues in Nigeria, hematologists in Israel also believed that beta thalassemia did not exist in Nigeria, but rather that sickle cell disease and alpha thalassemia are the major hemoglobinopathies prevalent in the country. For this reason, and to forestall the waste of my resources, my host at Hadassah made me analyze the DNA samples I brought from Nigeria first for alpha thalassemia. The study of alpha thalassemia was not my intention, since Professor A.G. Falusi had characterized the alpha thalassemia in Nigerians. Falusi, A.G. et al., 1987. However, reluctantly and to satisfy my host, I first worked on alpha thalassemia in all the 160 DNA samples I brought from Nigeria. During my first visit to Israel, I had learned some molecular methods, the experience which I used for the DNA extraction in my laboratory in Nigeria. My findings were like the findings of Professor Falusi, that the mild 3.3 deletion was responsible for alpha thalassemia in Nigeria. Both studies showed similar gene frequencies of 0.21% and 0.24, with 9% being homozygous for the deletion. Falusi et al., 1987, Kotila, 2012. Recently, Fashola et al. Also observed a prevalence of 47% in LD controls, like my observed prevalence of 51%, Fashola et al., 2022. Since our findings did not fully explain the low red cell indices in the study participants, my host finally agreed for us to look for beta thalassemia in the samples. Beta thalassemia. I alluded to the fact that my earlier studies on beta thalassemia were deficient because of the non-availability of automation in Nigeria. As soon as automation became readily available for red cell indices, I decided to repeat the study in a few patients using blood donor as apparently healthy controls. I collected samples from 160 individuals and ran a full blood count, including red cell indices, by automation and hemoglobin fraction by elution. I also extracted DNA from all the samples. The samples were analyzed at the Hadassah Hospital in Jerusalem. On completion of the analysis for alpha thalassemia, it was observed that 41.6% of the people who did not have alpha thalassemia deletion still had low red cell indices. This necessitated the need to sequence the beta globin gene of 10 selected people for beta thalassemia. None of the already described mutations in beta thalassemia were observed in the selected samples. This became a major setback for the molecular characterization of the mutation responsible for beta thalassemia among Nigerians. I had to come back home without achieving my objective, since I was not willing to leave my samples behind because I wanted to learn by analyzing them myself. However, the phenotypic expression still showed a possible beta thalassemia trait prevalence of 26%, agreeing with my previous studies, Kotila 2013. Not finding any of the already known mutations, though disappointing, was not unexpected, since some of the mutations are region-specific and considering the great likelihood of founder genes in our population. Subsequently, other studies in the country began to confirm these findings of raised hemoglobin A2 and beta thalassemia traits among Nigerians. Notable among the studies are two that were done at Lagos using automation for both red cell indices and hemoglobin fractions. The first study was conducted at Luth by Adeyemo et al. The study was carried out in sickle cell disease patients with a higher cutoff of 4% for hemoglobin A2. The analysis was done only in patients with low red cell indices. A prevalence of 10.6% was observed in the patients. In addition, a mean hemoglobin F level of 8.1% was obtained for the patients, Adeyemo et al., 2014. Similarly, at Lasuth, among sickle cell anemia patients, a prevalence of 34% was observed using a cutoff of 4% for hemoglobin A2. The mean hemoglobin F of the study was 6.9%. Akimbami et al., 2018. Recently, Durotoye et al. In Ilorin using capillary electrophoresis observed that 57% of blood donors had hemoglobin A2 of greater than 3.5%, Durotoye et al., 2021. Though these studies have shown variable prevalence because of the different populations studied and diagnostic criteria, however, it is established that the prevalence of beta thalassemia traits is higher among Nigerians than previously thought. Mr. Vice Chancellor, sir, clinical ramifications of beta thalassemia traits among Nigerians. Although I was yet unable to confirm the presence of beta thalassemia among Nigerians at the molecular level, I continue to see patients with likely beta thalassemia traits and make the diagnosis of the condition in my clinical practice. Over time, anecdotal reports of beta thalassemia cases began to spring up in the country and during our ward round at the UCH Ibadan. Beta thalassemia is now taught at both undergraduate and postgraduate levels, and students are examined on the topic. Beta thalassemia traits and type 2 diabetes mellitus. Upon sharing my thoughts on a possible link between beta thalassemia traits, metabolic syndrome with a colleague, Dr. Mabel Charles Davies, we designed a study in collaboration with Dr. Joko Adeleye. We were one of the first recipients of the University of Ibadan Research Foundation grants. The hypothesis was that there is an association between beta thalassemia traits, metabolic syndrome, and type 2 diabetes. Although we found that the mean hemoglobin A2 was higher in type 2 diabetes than apparently healthy control, the prevalence of beta thalassemia traits was twice as high in the control. Also, type 2 diabetes had more sickle cell traits than controls, and all type 2 diabetes patients with beta thalassemia traits had the sickle cell traits, while 75% of control with beta thalassemia traits had the sickle cell traits. Kotila et al., 2018. Beta thalassemia traits and tropical splenomegaly syndrome. The tropical splenomegaly syndrome is a clinical condition characterized by an enlarged spleen attributed to recurrent malaria infection. The nomenclature of the disease has since changed to hyperimmune malaria syndrome. Upon managing an elderly woman for myeloproliferative neoplasm who had been diagnosed with TSS decades before, as a young woman, we opined that the disease classes might be undiagnosed beta thalassemia. Kotila et al., 2019. Beta thalassemia traits and malaria. It has been shown that iron deficiency is protective of malaria, and iron supplementation increases its risk. Gohen et al., 2016, Armitage and Moretti, 2019. We also observed in a cross-sectional study that patients who were positive for malaria parasites had more iron overload and microcytosis than patients who were negative, and that anemia was more prevalent in those with iron overload and those who were iron deficient. We therefore concluded that background beta thalassemia might be responsible for this finding, Kotila et al. In print. Beta thalassemia traits and venous thromboembolism. Similarly, we observe that iron overload occurred in 40% of patients with venous thromboembolism in comparison to 7% in apparently healthy controls. Clinically significant iron overload was also seen in 22% of the patients and none of the controls. Furthermore, of the laboratory parameters, hematocrit, white cell counts, serum ferritin, MCH, and APTT differed significantly between patients with venous thromboembolism and healthy controls. By multivariate analysis, we showed that hematocrit, APTT, MCH, serum ferritin, and white cell counts explained 46% of the variance for VT, but neither hematocrit nor white cell has statistical significance. We again concluded that background beta thalassemia traits might be responsible for the iron overload observed in patients with venous thromboembolism, Kotila et al., 2022. Recently, the hospital procured a point-of-care device for the determination hemoglobin variant to replace the age-long cellulose acetate electrophoresis. This equipment is also capable of quantifying various hemoglobins. Analysis of the results from the equipment in the first 2 years showed a beta thalassemia prevalence of 36% using hemoglobin A2 cutoff of 3%. In addition, we have been able for the first time to document a prevalence of 21% for hereditary persistence of fetal hemoglobin among Nigerians. Furthermore, we deduced from the analysis that the prevalence of high persistence fetal hemoglobin was highest among hemoglobin S compared to hemoglobin A or hemoglobin AS, and that the prevalence of beta thalassemia trait was highest among compared to hemoglobin AS and hemoglobin S. We therefore surmise that the high prevalence of high persistent fetal hemoglobin is associated with high prevalence of sickle cell disease and beta thalassemia traits in the Nigerian population, Kotila et al., 2025. Symptomatic sickle cell traits. 1/4 to 1/3 of Nigerian population is known to be carriers of the sickle cell gene, Haematology et al., 1998. However, certain symptomatology, including sudden death, mostly reported in the USA, have been ascribed to these carrier states, CAC et al., 1987. Lately, two hematological malignancies have been observed to be associated with sickle cell trait in a case control study in the United States. However, life expectancy was found to be similar in people with or without sickle cell traits, Nike et al., 2018. When symptomatology has been ascribed to sickle cell traits, the diagnosis of sickle cell traits has been based solely on hemoglobin electrophoresis without recourse to quantification of different hemoglobin fractions, Kotila, 2016. In sub-Saharan Africa, where the prevalence of alpha thalassemia is high, the hemoglobin S levels in sickle cell traits individuals are usually between 25 to 40%, Kotila et al., 2007. Therefore, diagnosing sickle cell beta thalassemia traits based on the level of hemoglobin S alone may be inaccurate. The use of hemoglobin A2 cell indices may be more insightful. It is therefore likely that sickle cell traits have been thought to be symptomatic might have sickle cell beta thalassemia traits, Kotila et al., 2006. In conclusion, such efforts, along with the support of my collaborators, have showed a high prevalence of beta thalassemia traits and some of its clinical ramifications in the Nigerian population. Sustained that sickle cell trait is benign and not often the cause of symptoms ascribed to it. 3, shown the high prevalence of hereditary persistent fetal hemoglobin and its association with sickle cell disease and beta thalassemia traits. Recommendations. 1, molecular techniques should by now be commonplace in our universities. Molecular laboratories should not be limited to pockets of specialized laboratories or institutes within the hospital, within the university. There is no aspect of hematology or laboratory medicine now that does not require molecular methods in the diagnosis and management of their various disorders. Utilization of these techniques are mandatory for research to be publishable in contemporary hematology journals, empowering the laboratories to be at the forefront of cutting-edge techniques is to move the research of every aspect of medicine forward. 2, every laboratory physician is entitled to a laboratory space, which is why the design of the laboratory offices are with an adjoining laboratory. To be able to attract grants to equip the laboratory, there is need for support staff, laboratory technologists. In the early years of the university, when research output of the university was almost at par with those of the high-income country, there were enough technologies to assist with laboratory experiments. Each unit in hematology had 1 or 2 technologies specialized in each field of study to assist with research and students' practical. Now, hematology has only 1 technologist who is saddled with all these responsibilities. 3, it is important to resuscitate the Senate research grants of the university. Many lecturers contribute by applying for these grants. In the absence of sufficient funds, the grants could be restricted to the level of senior lecturers and below. Acknowledgements. To my Form 3 chemistry teacher, Mr. Osoyintui, who through his diligence ensured I did not derail as a young girl, thus making me stick to the sciences. I am grateful to Dr. Yemi JJ, who took me into hematology department and squashed my thoughts of transitioning through hematology to ophthalmology. Mr. Vice Chancellor, sir, I do not have any regrets, but rather grateful to him for helping me to fulfill my destiny. To Professors Rura Olashokunbi, Yetunde Akenova, Basil Ogunsanwo, thank you all for making me toe the line and making a hematologist out of me. To Professor Lucio Luzato, Fola Eson, Etim Essien, and Abasego, thank you all for laying a solid foundation for hematology practice in Nigeria. To Professor Akin Isaac Shodeye, I was not surprised when I learned from Ayo, your daughter, my classmate and friend, that I inherited your office. I indeed reap the benefits of the many prayers said in that office. It is therefore not surprising that I continue to work on hemoglobin A2 like you did. To the trio of Professors Philip Olatunji, Hianyi Okpala, and Maosi Okunade, I am very grateful for showing me the rope, though you laughed at me when I made silly mistakes, but I learned through it all, and you made my residency period fun and memorable. You remain my friends and mentors for life. To my colleagues, Professors John Olaniyi, Foluke Fashola, Titi Akingbola, we have indeed come a long way, mostly celebrating together. May it always remain so. To my younger colleagues, Doctors Peter Ogundeji, Oladapo Aworanti, and Chima Akunwata, you made working together easy without rancor. To my residents, past, present, and in the diaspora, it was Ogwa Alieze, Tobi Oladapo, Sunday Oladiran, Olaoluwa, Olaiya, thank you for teaching me also. To my BMLS students represented by Excellence Joshua, you are a part of my success story. I am indeed grateful to both the departmental and faculty inaugural committees for their doggedness towards making this inaugural a success. I thank every member of the department for their moral support and kindness. My research partners, I am most grateful to the following people for your invaluable support and guidance in the preparation of my dissertation for the fellowship examinations. Doctors Debo Adeyemo, Peter Olumese, Fumi Fawole, and late Professor Buki Fawole. I am grateful to Professor Dina Ben Yehuda, Dr. Farid Filon, Professor Ariela Openahan, Professor Debbie Rond, Alisa of the Hematology Department, Adasa Hospital, Jerusalem, for opening the world of molecular diagnosis to me. Professor Olufumi Adejumo, we started as friends from Olivet Heights, Oyo, but you transitioned to a research partner and brought the flavor of pharmaceutical chemistry and pharmacogenetics to my research. Thank you for being part of my story. My fellow grantees of the First University of Ibadan Research Foundation, Dr. Mabel Charles Davis, Dr. Jokotade Adeleye, and Professor Agbedana, I thank you. The bone marrow transplant team at Adasa, headed by Professor Ruven O, thank you for accepting me into your department. Collaborators at the Professor Oluwashola Special Diagnostic Center, UCH, Dr. B. Yogu, Mrs. Bamile Dele, Dr. Ladi Adegoke, Dr. Henry Ebili, I thank you also. Mentors extraordinaire. Professor M.T. Shokunbi, thank you for making me see the foolishness of declining the offer of subdean undergraduates of Faculty of Basic Medical Science, and then persuading me to do it. That position opened my eyes to the university system. I am eternally grateful. Professor Odunayo and Abimbola Oluwatosi, your academic, moral, and spiritual support and guidance are unequaled. Friends through thick and thin, Dr. Adedino, Dr. Oladipo, and Professor Olufumilayo Adejumo, Dr. Abiola Okeshola, Dr. Molara Adelowo, Dr. Mabel Charles Davis, Mrs. Fumi Arotiba, Dr. Samuel Ajayi, Professor Emmanuel, and Dr. Ronke Ajav. Reverend Kunle Oladipo, the pastorate and the pastorate of New Covenant Church, Model City Center, and the congregation, thank you for being a family church. Appreciation of special groups. UI MBBS Class 87, represented in this university by Femi Afolabi, Paul Onokoya, Charles Bekibele, Samuel Ajayi, Dele Kolude, Fumi Fawole, Eme Owaje, and Kayode Oshungbade. I also honor the memory of late Professor Bukola Fawole and late Dr. Teresa Elumelu Pupoliyi. Model City Reservation Area Community, Old Girls of Methodist Girls High School, Ifaki, Ekiti. Nigerian Society for Haematology and Blood Transfusion, I thank you all. To my family, my late father, late Major Michael Ayodele, words fail me to describe you, but just to say that you are an epitome of sacrifice, even in death. You are forever cherished. To my late mother, Mrs. Alice Abike Kotila, who taught me to read the Bible at a tender age and made me feel responsible for my younger brother, I am grateful for your beloved memory. To my stepmother, Mrs. Rachel Olufunke Kotila, who introduced me to the books of Shakespeare early in life and to the need to be studious, I thank you. To my siblings, Shegun, Benga, Olumide, Taiwo, and Kehinde, Femi and Muiwa, and their spouses, we share a legacy that we'll always be proud of. To the other third generation Kotilas, we have a godly heritage, which we shall pass on to the next generation. To Boluwatife, Oluwaseun, Oluwabukode, and Oluwabusayomi, the future is yours. To Mrs. Yemi Kotila, Mrs. Atinuke Jeminiwa, Mrs. Toyin Kotila, Mrs. Biodun Kotila, you are an integral part of the Kotila family. Your genes have helped shape the family. I thank everyone who kept faith with me during the ASU strike. To all who have made time out of no time, out of tight schedules, to honor my invitation to be part of this inaugural lecture, I appreciate you all.